In the remaining series of slides that I'll be showing, we'll describe the process of implementing the study, how the data were collected to actually measure these indicators. Then we'll say what the results were that we obtained with the changes within each of the two groups of hospitals and the difference between them that shows the value of accreditation in both physical terms and in monetary terms. And then we'll finally end up with some conclusions. As this slide shows, the data covered 7 measures for 3 years per hospital. And the compilation done by the staff of each of the participating hospitals averaged about 1 day per measure per year. And so altogether, it took about 21 person days of effort by the hospital personnel to look through the records. For example, the surgical logs to get the return to surgery, to get the ICU logs for the return to surgery, the admission records, to get the admission data, and so on. In some of the hospitals, it was done manually. In some, the information technology system collected these data. And from Brandeis University, Dr. Halassa and I provided external monitoring to ensure consistency in the data collection process. Once the data were collected, we did the data processing. We considered the year prior to accreditation as the before period, and then the 2 years ending in the accreditation years, accreditation were considered the after period. We made this decision because the hospital essentially had to get all of its procedures and data up to high standard and then be able to confirm that with the accreditation visitors. And so it really had those 2 years of high performance ending with the accreditation process. The analysis of these data involved us taking the average of the hospital-specific changes before the after minus before for each group. So that is, first for each hospital, we looked at where the hospital was in the after period, where it was in the before period, and the improvement that the hospital made over those time periods. And then we averaged that for each group so that we got the average improvement in the accredited group, which we hypothesized would be relatively high, and the average improvement in the non-accredited group, which would also, we hypothesized, show a positive improvement, but not quite as large. We then compared these two means using a standard statistical test, a t-test. We first looked to see whether whether the difference between the two groups was statistically significant, that is, more than would simply be obtained by chance, and we only included the ones that were statistically significant. And then we furthermore converted these to monetary terms for the indicators for which the results could be valued in monetary terms. So what are some of the results from this? One of the indicators, the financial solvency, we had to drop because we were not able to obtain complete data from the majority of the hospitals. 3 of the measures were statistically significant, and those were return to the ICU, the staff turnover rate, and the completeness of medical records. And for each of these statistically significant results, the study's hypotheses were confirmed. The improvement was greater in the accredited hospitals than it was in the non-accredited hospitals. For 3 of the measures, the results were not statistically significant, and these are the readmission to the hospital within 30 days, return to surgery within 24 hours, and the admission of international patients. Each of these, the changes were essentially the same between the accredited and the non-accredited hospitals. For the two results for which monetary evaluation was possible, first of these is return to the ICU within 24 hours. So the specific results here was a decrease in this bad outcome of 0.1% in the accredited hospitals, whereas the non-accredited hospitals actually got worse on this indicator, and they increased by 0.9 percentage points. The difference between those two measures in algebraic terms is a full 1.0 percentage points. And each admission to the intensive care unit means several days stay in the intensive care unit. And if one looks at the cost of those days in the intensive care unit and that 1%, the number of patients affected, it works out to be a monetary savings of $34,000 per accredited hospital per year. The next significant indicator was the staff turnover rate, and that rate increased by 3.0 percentage points in the accredited hospitals. That's a bad outcome. The more the turnover, the more the hospital has to train new staff and often experience a period of lower productivity while the new staff person learns his or her job. In the non-accredited hospitals, the staff turnover rate was substantially higher, being 13.0% per year. And so the savings in terms of the reduction in costs for recruiting and training new staff amounted to $53,000 per accredited hospital per year. The next group of results relates to the completeness of the medical records, and that increased quite substantially in the accredited hospitals by 27.6 percentage points. In the pre-period, only 48.9% of the required elements were documented in the record, and that went up a lot to 76.5% of the required elements being there. In the non-accredited hospitals, they got slightly worse actually, from 53.0% to 50.5% of the required items being there. If we add these two monetary measures together, we get a total of $87,600 per accredited hospital per year. And since we had 2 years of follow-up with accreditation, the total savings over that period amounts to $175,200 US per hospital. And if one compares that to the cost of the accreditation process of hiring consultants and staff time, it looks like just within that 2-year period, it looks like hospitals have very likely have benefited economically from the accreditation process. So in conclusion, the accreditation process demonstrated statistically significant improvement in quality as well as cost savings in key areas. And both the accredited and non-accredited hospitals valued the study for the contribution to staff skills in measuring quality. So I wanted to end this by thanking the organizers of the meeting for the chance to be part of your agenda, and for all of the participating hospitals and the Healthcare Accreditation Council for the opportunity to do this study. I regret that scheduling didn't allow me to be with you in person, but if you have any questions or comments, please use my email information or pass your questions on to the organizers of the conference, and they can email Dr. Halas and me, and we'll do our best to try to send you a prompt response to your questions. Again, thanks very much for your interest.